Welcome everyone. If you've just joined, so this is our webinar titled Let's Break It Down, Why Triple Elimination Matters for Hepatitis B. And we're going to get started in the next 30 seconds or so. Just wait for some few other colleagues to join in. Yeah, so please, if you're joining in, come along. I see we have around 32 speakers. We were expecting to have a bunch of colleagues join, so let's allow them a few seconds. And we do have a packed agenda for today, so I think we'll probably be starting in a few. Great, we have 44. I think we should be able to kick off. So thank you very much for joining, colleagues, friends, partners working in the hepatitis space, triple elimination. If you've just joined, just to give you a bit of a highlight, ahead of the World Hepatitis Day, Unitaid, PATH, the International Community of Women Living with HIV in East Africa, ICWA, the World Hepatitis Alliance, have co-organized this webinar, truly focused on examining the integral role of triple elimination in reaching global targets, especially the 2030 hepatitis B elimination targets. We do have a great panel for today. You'll be hearing from me. My name is Dr. Albert Komba. I'm the project director for SAFEStart Plus project, funded and we're implementing in partnership with Unitaid. But I also have a colleague of mine, a co-chair, who will be self-introducing in a minute. And so just to give you a bit of a highlight for this webinar today, the format will follow. First, we'll start with some opening remarks. You'll be hearing that from two of our colleagues whom we'll shortly be introducing, and then followed by a panel discussion. We have four great speakers that we'll be introducing. And then this will be followed by you, the audience, the wonderful audience, for Q&A session, which we're hoping it will truly trigger questions and discussions so as we can really drill deeper into this webinar. So again, my name is Albert Komba. I am the co-chair of this webinar, and I would like to take this opportunity now to welcome my colleague Rachel to introduce herself, but also give you a little bit of some more in-house. Rachel, over to you.
Thank you, Albert. And hello, everybody. Good afternoon, good morning, wherever you are. It's such a pleasure to be here on this, I think it's the second World Hepatitis Alliance, World Hepatitis Day webinar. So as Albert said, I'm here to co-chair. We have a great session booked in for you. Just in terms of housekeeping, Albert's already said there is an opportunity later to ask questions. If you have questions that you want to write down beforehand, because you will be able to put your hands up and speak during that time, please put them in the chat box or the question box. In addition, we also have translation available for you. So I'm not sure if there's a slide. Is there a slide, Alexandra? There is if you look at the bottom of your screen, you should have a circle which says interpretation on it. If you don't have that and you've just got a button that says more, press more, and then the interpretation button will come up. It's like a globe for anyone who hasn't used it before. Just press on there and choose the language that you would like to listen in. The only thing is if you could speak clearly and relatively slowly. I'm not like myself who tends to speak too fast so that the interpreters can understand. And just to say that Q&A box, that question box, should be on the bottom of your screen as well. So I'm going to hand back to Albert. Really looking forward to today, and thank you so much for joining us, Albert.
Right. So thank you so much, Rachel. Based on the agenda, we'll start with opening remarks, and we have two speakers. First, would like to invite the first speaker, Kelsey Barrett, who's a technical manager on the strategy team at Unitaid, working across maternal, newborn, and child health portfolios. And Kelsey will be sharing opening remarks with us. So Kelsey, over to you.
Thank you, Albert and Rachel, and thank you to our partners at PATH, the World Hepatitis Alliance, ICWEA, and everyone who's joining us today. As we approach World Hepatitis Day, this conversation is particularly timely. As you know, the elimination of vertical transmission of HIV, syphilis, hepatitis B has the potential to save the lives of countless newborns while improving health outcomes for millions of women and families. And we have the tools to achieve it, yet progress remains uneven, and hepatitis B continues to receive less attention and investment than its burden warrants. Too often, women living with hepatitis B are left behind, despite the availability of these highly effective interventions. So for Unitaid, this is why triple elimination is so important. And triple elimination really recognizes the simple reality that we know that pregnancy and childbirth provide one of the most important entry points for protecting the health of both women and newborns. And integrating services allows countries to deliver that protection more effectively and more equitably. Through maternal and newborn health platforms, countries have an opportunity to expand access to testing, treatment, prevention, vaccination, and follow-up services for all three infections, reducing missed opportunities and making care more accessible for families. So this opportunity is especially important because hepatitis B sits at the intersection of so many health priorities. It's not only a hepatitis issue, it's a maternal and newborn health issue, an immunization issue, a primary healthcare issue, and ultimately a long-term disease prevention issue. When we prevent hepatitis B transmission today, we're also reducing the burden of liver disease and liver cancer for future generations. At the same time, the broader global health landscape is changing. As countries face increasing pressure to sustain progress with limited resources, integration is no longer simply a desirable goal, it's a practical necessity. So triple elimination offers a way to build on existing platforms, preserve hard-won gains, and deliver greater impact for women and newborns. So this is one of the reasons that Unitaid and partners launched SAFEStart Plus, the project that Albert mentioned and leads. SAFEStart Plus is working with countries and partners to generate evidence on how integrated triple elimination approaches can be introduced, scaled, and sustained through maternal and newborn health services. But one lesson has already emerged clearly. Success depends on more than technical solutions. It requires strong country leadership, meaningful community engagement, and collaboration across programs and partners that have not always worked together. This is why it's particularly important that we have today's discussion, which brings together voices from communities, ministries of health, civil society, WHO, and implementing partners, as triple elimination will require all of these perspectives. As we look towards 2030, ensuring that hepatitis B is fully included in elimination efforts will be one of the defining tests of our commitment to integrated people-centered care. Triple elimination is about more than preventing the vertical transmission of three infections. It's an opportunity to strengthen the systems that women and families rely on and to build a more sustainable foundation for maternal and newborn health. If we succeed, we'll not only accelerate progress towards elimination targets, we'll help ensure that women living with hepatitis B are no longer left behind while building stronger health systems for future generations. And that's the opportunity before us. I really look forward to today's discussion, and thank you so much. Back over to you, Albert.
Thank you, Kelsey. Thank you so much for your opening comments. Absolutely brilliant, and it sets the scene really well. I'm now going to introduce our next speaker, who I think probably needs no introduction, Gloria Antinge, who is the Executive Director of Rosa Development Initiative and a human rights lawyer focused on gender and global health. Gloria's going to share her reflections from her lived experience and why scaling up triple elimination programs will be transformative for women living with hepatitis B. So welcome, Gloria. I saw you just now. You are here, I know. Whoops, unless you've just suddenly, I think we might have lost Gloria. I think her camera might, I think we just lost her. I wonder if, oh, there you are. Hello.
Hi, Rachel.
I thought I lost you there. Oh,
yeah,
so nice to
went
see
off
you.
and just came back.
Okay, so I was just introducing you to say that you were going to share your reflections from lived experience and why scaling up triple elimination programs would be transformative for women living with hepatitis B. Over to you.
Thank you so much. Thank you for having me. It's an honor to be on this webinar and to share my personal experiences and reflections. So as a person living with hepatitis B, I would say that triple elimination is one of the greatest promises we have to improve the lives of women as well as their children and improve and then be able to prevent liver disease, including cirrhosis and cancer for future generations. I was first diagnosed with hepatitis B in 2009 during routine investigation. And then it was followed by a lot of wrong information. I was misguided about this disease, about the prognosis, about what to do to take care of myself and all of that. It was also highly stigmatized. So my elder sister advised me early to not share my status with other people because it's going to make them feel scared of me, avoid me and all, because in our community, people still do believe that hepatitis is transmitted through sweat, through casual contact, like sharing food, sleeping together and stuff like that. So I learned early to keep my status to myself and try to only discuss that with people providing me care. Even in healthcare, many doctors did not understand the condition, and then they were unable to provide me proper guidance on what to do, what next steps to take, and all of that. One of the things I confronted was the problem of herbal treatment. Someone advised me to take a compound made from honey and garlic and some other substances to cure hepatitis completely. I tried that for close to a year and it didn't work. And in the hospital, I was not really also guided about what to take. Some of the doctors would tell us, don't eat red meat, don't eat beans, don't eat fish. That's going to harm your liver. It's going to make you develop serious liver disease and die. It was later that I began to learn more about the science of hepatitis that I discovered that was not true. Later on, I got married, and before my marriage, my husband's family was a bit hesitant about me getting married to him because one of their relations who had hepatitis B wanted to get married, and the church disapproved of the marriage because they felt it is sexually transmissible and it will not be safe for the partner, and that's how that marriage could not continue. So my husband's family felt, okay, why should it be different in their son's case? Like when it is someone else diagnosed with hepatitis B, like that he's considering getting married to. So my husband, being a doctor, took his time to explain to his family, and then they understood and appreciated that it wasn't as bad as they thought, that I could manage the condition and live healthy, normal life without transmitting the virus to him, especially because he has been vaccinated. Then came the point of having children. When I had my first baby, we had access to vaccines for him immediately as recommended. Although all the services were fragmented. I had HIV and syphilis testing within the facility, but I had to go elsewhere to the lab to test for hepatitis B and C. And then when the test returned positive, they asked me to do further investigations away from the point of providing antenatal care. It also became more difficult when I had my second baby. That was during COVID, and the vaccine was not readily available. And then it became worse because he was admitted within few days of birth. He was admitted the first day of birth. He was discharged 2 days later and then readmitted. So throughout that period, the pediatrician told me that we cannot prioritize vaccine. We had to prioritize his recovery. On the other side, the pediatric team was also telling me to get immunoglobulin for my child. They insisted that it needed to protect him as a hepatitis B exposed infant. It was not available in our locality here, and it was a problem for me. Like, I was under serious stress because they kept on reminding me that I might pass on this virus to my child if I don't get immunoglobulin. But there was no movement. I couldn't get this drug sent to me, like in Jalingo, Taraba State, Nigeria, where I am, and that is how it passed. But it was, I think, 3 weeks or so later, after my baby was born, that he eventually got his first shot of the hepatitis B virus. I felt that these things could improve if these services were all provided at the point of receiving antenatal care or at the point of delivery. If I had these services in the labor room, or if people who provide vaccine services work like run shifts that allows them to vaccinate babies who are born in the evening and during weekends, then of course, it was compounded by the lockdowns at that period of the COVID that did not allow movement of essential medicines, including vaccines at that time. So what I would say about how triple elimination will transform will be transformative for women living with hepatitis B is that it at least will make us to be able to access these services faster and then in one place. So it doesn't have to increase the number of visits we pay to the hospital for us to access some of the testing that we need. It will also increase our ability, like it will triple elimination will enable providers to see both baby and mother, not just the baby. Like, let's protect this baby from what the infection the mother has, but they'll be able to see how they might be able to protect both baby and mother through triple elimination services that prioritize both the baby's safety and the mother's well-being over the whole course of life. So I think that by investing in triple elimination, we can ensure that women access these services timely, babies are vaccinated on time, and then you can also reduce the costs in terms of time women go to the hospital, costs in terms of out-of-pocket expenses, and so on associated with hepatitis B testing and treatment, and also the vaccination of babies who are born to hepatitis B mothers. Thank you very much.
Thank you so much, Gloria. Indeed, such wonderful and inspiring remarks. We truly need more than technical solutions. So now we're going to be transitioning to our panel discussion. And colleagues, this panel session is titled Scaling Up Access to Hepatitis B Prevention Care through Integrated Triple Elimination Programs. And we have 4 speakers, and I would like to start by inviting the first speaker, who also needs no introduction, but I have a pleasure to call in a friend of mine, a colleague, also a partner in work on triple elimination. This is nobody but Professor Fumi Lesi, who currently leads the hepatitis team in the global HIV, hepatitis, and STI programs at the WHO. Fumi, I have the first question for you. What have you observed as the most significant gaps preventing countries from advancing hepatitis B within triple elimination efforts? And if you can also give a little bit of insights on what integrated approaches or innovations are proving most effective in helping countries to move towards validation. Over to you, Fumi.
Thank you so very much, Dr. Albert. Thank you to SAFEStart and to Unitaid. And I really want to appreciate Gloria for that amazing testimony. And I'm so excited and happy that she could share that experience that can guide us. In fact, Albert, everything you said, triple elimination really is a game changer. Now, before I respond to your question, just to flag a few things. As you know, the Global Hepatitis Report was released 2 months ago or so. And just to share with you that more than 128 countries have already adopted policies for hepatitis B screening by 2025. So they have the policies for hepatitis B screening during antenatal care, but amazingly, less than 40% have achieved nationwide implementation, revealing a striking implementation gap of over 60%. And this gap is particularly concerning in the Africa region, which accounts for nearly 70% of new infections globally. I also want to mention that when we talk about hepatitis B, one of the most striking findings, even from the Global Hepatitis Report, is the liver cancer rates. And the report shows that in the past 10 years, liver cancer has risen by 17%. In fact, 3,500 people are dying every day from hepatitis B and C. And people ask, so what is the connection between triple elimination and liver cancer? Just to mention also that what we dread the most from hepatitis B is the liver cancer that it causes. And children that do not have access to vaccination and care in Africa, there are more than 2.6 million children in 2024 in Africa who neither received vaccination or PMTCT services. And these children continue to contribute to the pool of liver cancer in early adulthood. So I'm just setting the scene for the gravity of what we're discussing and the very important role that hepatitis plays in this. You talked about what are the implementation gaps. I think we know a lot of them. We're talking about insufficient and fragmented financing. We're talking vertical program structures that separate maternal and child health, vertical immunization, vertical HIV services, weak health systems, inadequate laboratory and diagnostic capacity. We know about workforce constraints. And therefore, when we talk about triple elimination, we're talking about integration using pre-existing platforms that have worked so well for viral hepatitis. So when we talk about the solutions you highlighted, we know that countries must include hepatitis services within various systems, including HIV, maternal health care, immunization, primary health care programs, rather than develop new pathways for hepatitis B. And this integration will allow the use of existing laboratory supplies, existing supply chain, existing workforce, existing financing to improve both the equity and the sustainability. So the triple elimination model is one of the leading models to show us and teach us how to integrate. So coordination, as SAFEStart is beginning to lead with, will really support the integration of hepatitis B into the HIV and STI systems and strengthen triple elimination. So going forward, how do we coordinate? How do we ensure that we do not have vertical systems, but a well-coordinated system for implementing triple elimination? I'll stop here, and I'm sure there will be lots of questions, and I can delve further when we have further questions. Thank you very much, and over to you, Albert and Rachel.
Thank you, Fumi. Fantastic as ever. I think really important integration. And thank you also for highlighting, the connection to liver cancer, which, these are all needless deaths. These are people who did not need to die. So it gives me great pleasure, though, to move on and to introduce Dorothy Nambantu, I'm going to say it wrong, Namtamba, who's the Deputy Executive Director of the Community of Women Living with HIV in Eastern Africa. Are you there, Dorothy?
Yes, I am.
Hi, how are you?
I'm good, thank you. How are you?
Fantastic, thank you. Dorothy, I have a question for you. Are you able to answer it? You're okay?
Yes, I am. And I'm able to answer the question.
Brilliant. So I just wanted to ask you, from your point of view, why is triple elimination important to eliminating HIV as a public health threat? And also, how can networks of people with lived experience and community organisations be better engaged in driving triple elimination?
Thank you so much, Rachel, for the question. And thank you so much, WHA for World Hepatitis Alliance for organizing this webinar, and also for the previous speakers for putting us into the perspective of where we are, but especially my sister, Gloria, for giving us that lived experience. For the sake of my bandwidth, I will not keep my video on. I may just switch it on briefly and then switch it off. I'm sorry about that, but please bear with me in case I also have background noise. I hope you can hear me very well. Can you hear me?
Yeah, we can hear you brilliantly, very clearly.
Okay. Okay. So I'll keep my video off for now, but I'll go straight to the answer to the question. Yeah. So triple elimination. Why it is important for to eliminating HIV as a public health threat. I really see this as an opportunity because when you look at triple elimination, it is addressing not only HIV, but it is also addressing the 3 diseases, which include hepatitis B, but also syphilis. And for HIV, transmission of HIV from the mother to the baby, it really focuses on stopping the transmission during delivery, during pregnancy, but also during breastfeeding. Whereas we know very well that these three diseases really have the global cause of the preventable stillbirth and also child mortality. If they are combined collectively, they really they are great contributors to this. So when you look at HIV, then in totality, it cannot stand alone. It also needs the sisters to, in fact, contribute to this high burden of the preventable stillbirth, but also the child mortality deaths that are being raised by these three diseases. And for an HIV, for a woman who comes to the facility, if you are being held if you find the services that are really integrated in a way, then you realize that definitely HIV, you'll be able to save your baby and you'll not be able to transmit any of these diseases. We are also looking at the fact that you can get beyond this protection. You can get the prevention of these diseases, especially HIV, if you are HIV negative. But even if you are HIV positive, then the chances that you are able to still protect your baby, because one of the things that is done is that immediately you are initiated on treatment. But we also know that should you also have any of these other two diseases, which include syphilis, but also hepatitis B, then you are really highly vulnerable to the HIV infection, because with syphilis, of course, it renders you very vulnerable to all the other STI infections, but will affect your baby, but most especially passing on the diseases to your baby, and including HIV. With the EVT, we also emphasize the importance of integrated care and a person-centered approach to the health facility. So when you enter the facility, you are not looked at just as an individual, but we are looking at with EVT services that they're addressing HIV, but also other diseases. You're looked at in totality. So that gives you the opportunity not to come back to the facility over and over again. And there is that comprehensiveness. Where we are right now, we're looking at integration. So EVT gives you the opportunity to get the integrated services. And when you also consider some of these low-income countries where we are in our sub-Saharan Africa, we carry the highest burden of all these infections. And the health systems are often underfunded and fragmented. When you're establishing separate vertical programs for HIV, syphilis, but also hepatitis B, they lead to duplication. There is really insufficient resources and allocations always around missed opportunities, especially if you're referred from one facility to another to access these services. So they are not readily, sometimes if they are not readily available if they are really fragmented, but should they be together, then you know you are being considered in totality, and in addition to the fact that you're able to access all these services that contribute to not only your health, but also the health of your baby. Also just wanted to add that in the HIV clinic, it carries really this heavy social stigma that deters most pregnant women from seeking testing and treatment services. But if there is the integration of the HIV services into the broader, but also the routine maternal health packages, including syphilis, but also hepatitis B screening, it kind of normalizes the clinical encounter, it reduces stigma, and increases overall service uptake. So I feel those are the really some of the very key important issues that I wanted to bring out. In fact, in relation to the importance of eliminating HIV as a public threat, but also the fact that you are in this clinic when your infant gets exposed, just like Gloria alluded to her testimony. She said that you are able to receive coordinated postnatal interventions, including the HIV antiretroviral prophylaxis and hepatitis B vaccine birth dose, but also appropriate follow-up, so that we are seeing that elimination of HIV is not only on its own in children, but also as a public threat. Even the mother the mother's health is important because you are the one who can look after your baby best, and you and definitely will be eliminating not only HIV but also the 3 diseases. I'll quickly go to how can networks of people with lived experiences and community organizations be better engaged in the driving of this triple elimination. I want to start by saying this is majorly through the meaningful engagement. And when you say meaningful engagement, we are looking at the fact that we want to focus on the respectful but also dignified and equitable inclusion of individuals with lived experiences with a range of processes but also activities, valuing the lived experiences as a form of expertise but also applying it to improve the health outcomes. That we are not only receivers of care, but we come on board with a lot of expertise that is very, very important, not only in program implementation, but also informing the kind of decisions that need to be taken. So when we talk about this meaningful engagement, we also look at the fact that people with lived experiences, we found that experiential expertise that professional clinicians cannot replicate definitely, and we can be engaged at different levels. We are either the peer navigators, we're the mentor mothers, the linkage facilitators, name it. And we serve as that vital link between the communities, but also the clinics, the health facilities that exist. And we look at issues of adherence and retention. And beyond that, we also have the expertise in putting into the different processes that programs do bring on board, whether it is reviewing protocols, we have that community arm. So that true engagement really requires that this engagement really is sustainable. Therefore, we must move away from bringing people with lived experiences merely as volunteer labor, but also that we can be engaged in the program leadership, recognizing the peer expertise, but also the professional work, and compensating the partners for their time, but also the effort. I want to say that this is something that we have taken up, especially I want to thank the SAFEStart partners that it has been something that has been embraced in our project, and also Unitaid for seeing the community arm of this arm as equally important as the other arms. And we have been able to do this through the community clubs that are composed of constituting the community clubs in our project that are composed of individuals who share the common identity, geographical, but also cultural experiences. And there are the voices of the community perspective and the priorities into the project, but they also protect the communities from any exploitation or anything that may come in with the project. But apart from that, and in the interest of time, I wanted also to say that we as a meaningful engagement also looks at us as the communities being able to raise awareness among the women in the reproductive age, but also their families about the need to access these available services. And then also improving quality. Locally, through we improve the quality, the project quality, but also the impact, the local knowledge and the lived experiences. They ensuring that the work is guided by the robust understanding of the community, but also the relevant data that can lead to more effective programming, but also implementing of the needs of the community. We have also been able to do this through the community-led monitoring, which is highly effective, an effective mechanism where local communities systematically monitor the quality, accessibility, and also availability of the health services. And we are able to track some of these things in real time, and we are able to give feedback, alerting the health authorities and also the decision makers. So we sit together as equal partners, and we look at all these issues, but also the missed opportunities that could be explored. I wanted to end by saying that definitely meaningful engagement of communities is very key, but we also look at issues of advocacy without where really maybe the health facilities may not be that is really our core role as communities, where we can cause change through our advocacy by working together with the hepatitis, HIV, but also syphilis community organizations. We push for a comprehensive integrated approach for EVT in all the three diseases through the triple elimination. So advocacy is very core, but also addressing the social determinants of health, especially the stigma and discrimination, the limited awareness, and the myths and misconceptions that some of these diseases do bring to the communities. Therefore, when we're looking at the fact that we are considering communities and we are saying that we are all equal partners in implementation, but also when we are being engaged at all different levels, whether the project inception, but also implementation, evaluation at all levels. I want to hand over and thank you so much. Apologies in case I took more time.
Thank you so much, Dorothy. Indeed, triple elimination is a game changer, and you've highlighted a lot of those facts. We are running a little bit out of time, lagging behind by a couple of minutes, so I'll be requesting politely, kindly, the next speakers to try to stick to time. We have 75 folks on the call, so it will be good to give them some opportunity to also come in with questions. So I'm going to move this over to the next speaker. This is none but Mr. Mbai Njie, who is the Deputy Program Manager, EPI, the Minister of Health, the Gambia. And I'll move straight to the question. Mbai, Gambia has been actively spearheading initiatives to enhance access to the hepatitis B birth dose vaccination. Can you please speak about some of the recent advancements the Gambia has undertaken to strengthen both access and the uptake of the birth dose? Over to you, Mbai.
Thank you very much. Good afternoon, everybody. Thanks for organizing this very important webinar. Just going straight to the point, the Gambia has been doing very well in terms of hepatitis B birth dose because we introduced the vaccine long time ago, around 1993. And then since then, the Gambia have been giving out the hepatitis B vaccines. But recently, we have seen some challenges in the birth dose, and then we have taken drastic measures in trying to improve on the hepatitis B birth dose coverage. One of them is like the tax shifting, because for the Gambia, immunization is conducted by public health officers, different from nurses, and they do not work at the labor wards. So one of the things that we did was introduce shift night duties and then also off work duties, like for example, 24-hour round the clock in major health facilities and hospitals, where almost about 80% of deliveries occur. They have definitely have these public health officers assigned, and then they will be working there on shift to improve on hepatitis B birth dose coverage. We do not only stop there, because like public health facilities or private health facilities are also conducting deliveries. So the EPI provided cold chain equipment and vaccines to all these private health facilities, and then wherever they are in the country. So they are also providing immunization services, and birth dose is part of the antigens that they'll be giving. And then immediately after a child is delivered, they definitely provide give this doses. This has definitely improved. I think some of you have seen the WHA data that was published yesterday, and then our coverage have moved a little bit higher. We were at 39% in 2024, but in 2025 we have moved up to about 50-something percent, 52%. And then as we speak right now, because these measures that we took, we are taking towards end of last year and this year, and then this year so far, the data from January to June have shown that like we have definitely achieved above 60% of hepatitis B birth dose given to children who were born at the health facilities. So we also try to make sure that we do tax shifting. Some of the midwives are trained, and then they are provided with the vaccines, so that during child delivery they also administer the vaccine together with any other childcare interventions that they do during childbirth. So these are measures that we have also taken. Um, uh, we are also only not covering measuring timeliness, but also not coverage, but timeliness also is very, very important. So in our data recording tools, because Gambia have moved from paper-based system to electronic registry. So this is an indicator that is being monitored at all levels to see what is the percentage of child hepatitis B birth dose given at each level of the country, from health facility level to national level. So in our electronic immunization register, this tracker that we are using, it's also been tracked. So we have also utilized leverage on child welfare, maternal and neonatal child health services. These are integrated activities looking at the pregnant woman and also the child holistically. So the EPI have definitely partnered with the child health care units, maternal and child health care unit of the ministry, and then we are working very closely in ensuring that hepatitis B birth dose and any other service that they provide, like the triple elimination studies that are being conducted in all these major health facilities, hepatitis B is given a priority, and also vaccines are always available. So basically, these are the things. And then also in our last meeting, I also reported that the Directorate of Public Health Services have instructed all regional directorates and then health facilities, so that this staff 16 is definitely emphasized, whereby where the public health officers are not available, vaccines be provided to the midwives to administer hepatitis B birth dose. And these are the strategies that we are definitely doing in addition to the existing strategies that we are already in place in the Gambia to improve on hepatitis B birth dose. Yeah, so thank you very much.
Thank you, Nietzsche, and thank you so much for, amazing the work that you're doing in Gambia. Thank you. We're going to move across to Nigeria now, as we are running out of time quite quickly. It gives me great pleasure to introduce you to Dr. Afolabi Odamide, who is the public health physician and engagement manager at the Solina. And I have a question for you. Hello. Hi.
Hi, Rachel.
Sorry
can
to
hear
be
you clearly.
rushing. I'm just conscious that I want to be able to ask you this question, and we're running out of time. So I'm going to ask you the question. Perhaps you can answer. So Nigeria has developed a national framework and a roadmap for the triple elimination of HIV, syphilis, and hepatitis B. Perhaps could you tell us what are the main barriers to translating these policies into routine hepatitis B services for pregnant women and newborns? And perhaps alongside that, how can Nigeria strengthen the full pathway from antenatal screening and maternal assessment to antiviral prophylaxis and timely both dose vaccination, infant follow-up, and continued care for women living with hepatitis B? It's a long question, but I think you've got it already. Can I pass over to you?
Thanks, Rachel. Thanks to everyone here at the consortium that has put this platform together. So Nigeria as a country, we've made a lot of progress with developing a national framework and roadmap for triple elimination. And then the challenges we see are majorly across service deliveries. First is integrated testing for hepatitis B for pregnant women in the ANC. So for Nigeria, the country, in most contexts, we've made a lot of progress testing across HIV and syphilis in the ANC, but hepatitis B testing is still sort of underperforming. And most women in public health facilities are required to pay out of pocket to be able to access some of these testing services. And sometimes this testing is usually not done at the antenatal care. They're required to go to the labs to get this testing done. Secondly, linkages to referrals and linkages are usually not properly strengthened. A pregnant woman that is tested positive for Hep B is usually not assessed and either assessed for prophylaxis or assessed for lifelong treatment. So these are some of the gaps: timely assessment and timely referral. The third bit is hepatitis B backdose vaccination for the neonate or infant. In most settings where this is done, when the infant is delivered, we usually wait for the immunization clinics. The backdose vaccination is usually not available at labor wards. So these are some of the gaps. For out of facility births, in occasions where there are outreaches, that's when these children get this backdose vaccination. And then the timeliness of the vaccination is usually not, usually an issue. Then the fourth is using data systems, commodities, and source structures are still a bit fragmented. For the HIV systems, immunization systems, and maternal and child health programs, there are sort of different programs, commodities, data used for decision makings with various reporting channels. So everything seems to be a bit fragmented. And last but not least, more of continuity of care for the mother and the child. There's usually a lot of focus on prevention of mother-to-child transmission. I remember for the HIV program, there was an option B program for the mother and ANC, and then it later moved to option B plus. So we are looking to see if this has also been translated for the hepatitis B program, taking care of the woman beyond the pregnancy and the postnatal period. So we can address some of these barriers by first of all ensuring full integration of the triple elimination test and treatment cascade across public, private, and faith-based facilities. There are opportunities for full integration and that's what we are trying to do on SAFEStart by introducing and making case for the 3-in-1 commodity that test across HIV, syphilis, and hepatitis B, and helps us as a program move from under testing for hepatitis B to moving us from around 40% hepatitis B testing in ANC to as much as 80%, 90% where syphilis and HIV testing is. Second is to ensure prompt linkage and referral for the pregnant woman that has been identified as hepatitis B positive in ANC. We want them to be properly, evaluated by the healthcare workers and then, stratified if they require prophylaxis or they require, lifelong treatment, and they should be enrolled and adequately linked from, these smaller facilities to facilities where these services are offered as an integrated package under one roof. Third is the backdose vaccination for the child. We want to make cases where the immunization or the vaccine is available in the labor ward, and then also strengthen referral systems from the community using existing community structures to ensure there are clear pathways for referring women and their unborn and their babies from the community down to the facility to receive adequate backdose vaccination. I think the last bit is to ensure full integration and system readiness by using data reporting for across all systems, immunization, maternal and child health, the HIV program, infectious disease program, to ensure everything is fully integrated for commodity procurement to the last mile delivery, data used for decision making, and then joint supportive supervisory visits from the ministries and implementing partners down to evaluate what is being done. So the program will continually be continually improve on existing program structures. And I think in a nutshell, it's important for Nigeria to align everything, both its finances, efforts at capacity building, supervision, data systems, both at the national level and subnational level, ensure there are adequate budget lines for integrated programming, not just for HIV, including syphilis, hepatitis B, full integration, full funding, and then eventually the key message for us is as Nigeria, we should not create siloed programs. We should create integrated programs for the pregnant women, and we should ensure that the woman is being catered for beyond the pregnancy and postpartum period. I think success for Nigeria should not be measured by the number of women screened. It should also trickle down to the women that continue, that are able to complete, service delivery across various cascades in the testing and treatment pathway, down from diagnosis to maternal and child health care for the infants. So I'll pause now. I think I try to manage the available time. Thanks, and over to you.
No, Fantastic, thank you. And what a great message as the last of the panel there. Fantastic, that true integration and a framework to do it. We have got 10 minutes for questions, so thank you so much. There is a box there, which is now on the bottom. I don't know why, which no one's written any questions in. I wonder, is there anyone who'd like to put their hand up and make a comment or have a question perhaps for one of our presenters? We can unmute you so that you can actually speak. I can't actually see the list, so we're reliant on Ben and Alexandra here.
We don't have anyone with their hands raised at the moment, Rachel.
We don't. Okay, so maybe we do have a few other questions for our panel. If the panelists wouldn't mind putting their cameras on. So we do have we've got 10 minutes, so we could just have the same question to everybody. What do you think, Albert? Shall we go for one question, the same question to everybody with 10 minutes left?
I think so.
We also have a hand raised now.
Oh,
yes.
Oh, so shall we go? Let's go hand raised first, and then we'll do one quick question for the panel.
Right. I think Ben's unmuted. Amadou? Barry?
Amadou.
Thanks for giving me the opportunity. I would like to ask Dr. Ahmad Al-Mali, the last presenter. He's right. We have programs like Gambia that is doing all it can to make sure that children receive these life-saving vaccines within 24 hours. You mentioned that we have the tools, but how we do it. So I would be very much interested if there are policy documents that can support the integration of these multiple services. Thank you.
Yeah, thank you. I wanted to be sure what the question was. Is it the way forward to ensure, the infants receive timely part dose vaccination, or you're also asking if, the tools or the policy documents are available in country? I wanted to be sure what your question was before I go ahead and answer. Barry.
Yes, thank you. It's about integrating the processes in such a way that, because I understand we have different departments that are involved in maternal and child health. And like Dr. Mbai alluded, these different stakeholders must come together to ensure that children or women receive these life-saving vaccines on time. So I was just asking if there is, if you can maybe just elaborate on the processes that you have, bringing all these different stakeholders together.
Yeah, thanks, Barry. I think for the SAFEStart Plus project, we do have a platform, similar platform, where we engage with other countries to solve, share lessons that we've learned from program implementation, from the policy level, governance level, service delivery, commodity-wise, various building blocks for the HSS, as advised by the WHO. So we do have similar platforms, and we're also actively engaging existing community structures so that we ensure everyone is actively carried along. Yes, for Nigeria, we do have policy documents that have been validated, and I think what is left is sign off from the coordinating minister of health. And once this has been done, this will be rolled out from the national down to the subnational level. And this will also be reflected in the policies, the national guidelines, down to, the tools the healthcare workers use on site to ensure quality service delivery is offered to, the population of interest, who are the pregnant and breastfeeding women and their infants. Thanks. I hope I've been able to answer your question.
Brilliant, thank you. I think a really good question that goes with this actually is to Fumi, if that's all right. Fumi, what practical strategies could countries adopt to address barriers to triple elimination and progress towards validation? Two-minute answer. Big question, 2 minutes.
I think it's a big question. I think a lot of the answers have come from what Dr. Falabi Olumide has said. But I think an important thing we haven't talked about a lot is collaboration. We recognize that there are 3 diseases here, 3 vertical diseases. There's the HIV PMTCT and the HIV disease, the syphilis, and the very complicated hepatitis B disease, including immunization. And the triple elimination is trying to bring together these three programs. So the role of collaboration is essential because there's no single program. There's no single individual. There's no single stakeholder that can deliver the full package of care across the diseases. So if you talk about how can we overcome it? First, we need to start talking as stakeholders. The government will take leadership, and the government agencies, apart from the programs, we're looking at the data agencies, the laboratory agencies, the healthcare workers. We are looking at the community. And our colleague has told us the important roles of communities. Now we're talking about three communities, not just one community. There's the HIV community, there's the hepatitis B community, and there's a growing syphilis community. We're talking about developmental partners like WHO. And somebody asked the question about guidance. We have a guidance for triple elimination, for implementing it, and I shall put it in the chart for people to see. We're looking at academic partners. We're looking at the private sector. So collaboration, coordination to develop every step of the way is key. I'll stop here. I'm looking at the time, and I would like my colleagues to also weigh in on this. So my takeaway here is integration definitely requires collaboration. And again, maybe some innovation as well. Dr. Falabi talked about test kits. We have the dual test kits. We believe that the presence of triple test kits will really accelerate inclusion of hepatitis B onto this triple elimination platform. Thank you very much, and over. I'll stop.
Thank you. I mean, maybe just a quick word, because I do think absolutely. Kelsey, any comments around the, effective partnerships or anything, the collaboration that Fumi talked about there? We have like 1 minute each for each of our presenters.
Thanks. I think Fumi spoke to collaboration really well. I think if we work separately, right, we'll miss opportunities to reach women and newborns with comprehensive care. So that's absolutely critical. When it comes to effective partnership, that really starts with country leadership, but it also means bringing together communities, civil society, implementers, technical agencies. Fumi spoke to this as well. Working all together with donors as well towards a shared goal. And the best partnerships are those where each stakeholder brings their strengths and there's alignment around a common plan. And each focuses on what matters most. So some of the implementation guidance that Fumi spoke as well, there's guidance that can support development of a common plan that can be built upon as well. And this is all in the aim of making services simpler and more accessible to women and families. Thanks.
Brilliant, thank you. We've got a couple of minutes. So Gloria, I saw you a minute ago. Gloria, for you, on the ground, what does a good partnership look like?
Thank you very much. I'm happy to contribute to this important aspect of the webinar. I would say that a good partnership is respectful. So like Dorothy said, lived experience is expertise as well. So if government is respectful of persons with lived experience and carries them along, centralizes their experiences and their voices in program planning, design, and implementation, including evaluation, I think those partnerships will be more effective because we are able to bring perspective from people with lived experience. We're able to point out ages, places that need improvement, and how things can be done better. I think if our partnerships are more respectful and more inclusive, they can thrive and help deliver triple elimination successfully.
Perfect, absolutely perfect. I'm going to hand back to Albert for the final words, and I'm sorry that we don't have an opportunity to ask more of our panel for their views, but I'll hand back to Albert for your final, I think we're right on the end, for your final thank yous and views, takeaways.
All right, thank you so much, Rachel. So I would like to take this opportunity to thank the audience for participating. Rachel, I'm sure you'll thank the speakers, but I take this opportunity to do the same. I think we've seen huge policy to action gaps, and indeed, we require to have intentional, proactive country leadership and country ownership in order to succeed. We must ensure that we are smartly and strategically integrating from policy to systems to service delivery, and communities must be at the center. And healthy partnerships, strategic partnerships, accountability is very key for us to reach the final destination. So over to you, Rachel, for the last word as well.
No, I think you've said it all. Yeah, I guess I'm just going to finish on thanking our panel, everyone that's come here today. I think within everything that we've heard, from the lived experience through to the policy, through to WHO, from Unitaid, it is all about integration. If you just look at the panelists that we have today. So I think if we can replicate this and move it down to the ground, it's a no-brainer. It's not rocket science. I think that's the thing. You know, we spend a lot of time talking about this, but it's really simple. Listen to what was, you know, when I think about Nigeria and the plans, and Gambia and what they're doing. Yeah, I think that we need to more action and less speaking, because it's really simple. But from me, thank you all so much for joining. Thank you, Albert, for sitting here with me as well. And I look forward to seeing you all again soon, and hopefully next time we can have slightly longer. We all seem to rush, don't we? It's not long enough. But anyway, thank you very much, everybody. It's been such a pleasure.